Hi, and welcome back to Pharmacology of the Synapse. In this video, we are going to review the dopaminergic-based therapies for Parkinson's disease. Unfortunately, we do not have a cure for Parkinson's disease, nor do we have a treatment which can slow the progression of the disease. The treatments that we have are used to manage the various symptoms of Parkinson's disease. Most of the medications are designed to replace the dopamine deficiency that occurs in Parkinson's disease. They can be used as monotherapy or often combined together in advanced disease stages. The therapies must be highly tailored to the patient's symptoms as well as the disease progression stage. The ones we will discuss in this video are levodopa with carbidopa, catechol O-methyltransferase or COMT inhibitors, monoamine oxidase B inhibitors, and dopamine agonists. Levodopa is the main and most effective treatment for Parkinson's disease. It is a precursor to dopamine, and levodopa can cross from the bloodstream into the brain. Once in the brain, levodopa is converted into dopamine by cells. It is the only medication which has been shown to reduce mortality and reduce disability from Parkinson's disease. Almost all patients who have Parkinson's disease can respond with levodopa if a large enough dose is used. Bradykinesia, or slowness of movement, and stiffness respond better to levodopa compared with tremors. The dose of levodopa must be highly customized to the patient, as the effective dose can vary tremendously from patient to patient depending on their own symptoms as well as disease progression stage. The side effects of levodopa include nausea, vomiting, orthostatic hypotension, which is a drop in blood pressure when changing positions. Vivid dreams and hallucinations are possible in the later stages of the disease. The side effects of levodopa are mainly due to the peripheral actions of levodopa. Levodopa is orally administered, and it can be metabolized to dopamine outside of the brain by DDC, or dopamine dopa decarboxylase. This enzyme is also known as aromatic amino acid decarboxylase, or AADC. To reduce the peripheral metabolism of levodopa, it is usually given with carbidopa. Carbidopa can inhibit peripheral DDC activity, as shown in B here. Carbidopa prevents the metabolism of dopamine in the periphery, thus more levodopa makes it into the brain, where it gets converted to dopamine at the site of action where it is needed. Carbidopa and levodopa are often formulated together as Sinemet. Although levodopa is highly effective, there are complications of levodopa that can occur after years of treatment and as the disease progresses. They include motor variability, which is a variation in how effective the medication is. This leads to on periods, or periods where the medication is working and movement is improved, compared with off periods, where the medication is not working very well. Over time, levodopa will become less effective and effective for a shorter period of time. Thus, dosing frequency may need to be increased in later disease stages. Another complication is dyskinesias, which means abnormal movements. Dyskinesias can occur as choreas, which are involuntary squirming or rocking motions, and choreas often occur during on periods with levodopa and as thus a side effect of the medication. Choreas can be mild or severe enough to interfere with daily activities. Another dyskinesia is called dystonia, which are sustained abnormal postures. These commonly occur during the off periods and occur particularly in the feet, which can interfere with walking and standing. Notably, dyskinesias are not due to levodopa toxicity, nor do they indicate enhanced disease progression. In addition to levodopa metabolism in the periphery by DDC, levodopa can also be metabolized by the enzyme catechol O-methyltransferase, or COMT. COMT inhibitors, such as tolcapone, can extend the duration of levodopa, thus increasing the amount of on-time with an individual dose. These medications are only effective when taken in conjunction with levodopa, and by themselves don't have any effect on symptoms. Dopamine can also be broken down by another enzyme called monoamine oxidase type B, or MAO-B. Blocking MAO-B activity with selegiline can improve symptoms by reducing the breakdown of dopamine within the brain. MAO-B inhibitors can also be given in combination with levodopa to improve wearing off or motor fluctuations. Lastly, there are dopamine agonists themselves, which can act on the dopamine receptors in the brain. Dopamine agonists, such as pramipexole, produce less dyskinesia compared with levodopa. However, they produce more side effects, including hallucinations, sedation, and swelling of the feet, and are thus often not used until advanced disease stages. In the next video, we will discuss the non-dopaminergic based therapies for Parkinson's disease.